Good morning, everybody. My name is Maria Restrepo Toro, and I am the co-director of the New England Mental Health TTC, and we welcome all of you to the 2022 Innovations Conference honoring the whole person care in communities of color. We couldn't be happier to have partnered with all our partners in the region. We have an amazing group. We are here to celebrate a week in recovery, in whole center care, and you are going to be learning about innovating approaches. As a disclaimer, our technology transfer centers in the region are funded by SAMHSA in collaboration. I think Maggie, the slide before, please. Thank you. We have, this is under a grant from SAMHSA. So all during this time of the presentation, Dr. Miriam Delfa Ridmond is serving as the Substance Abuse Mental Health Assistant Secretary, and the opinions that are going to be expressed here throughout the week are for those of the presenters. Next. So a few things, please make sure that you have entered your full name and email addresses so we can use to register and confirm attendance. So you can get all the post-event materials, including all the recordings that are going to be archived for today and for every day of the week. Please, microphones need to be muted during these presentations so we are going to be actively using questions at the end, and you can request to be open the microphone via text. Closed caption is available for this event. Please make sure you click on the CC item bottom if you need the transcription option. By consenting to the recording, then we are confirming that you are okay with us recording. And if you have any technical issues, please send direct message via chat box. The last thing we're going to do to center is, Maggie, next, please, the language statement. Our network, and that includes our partners as well at the ATTC New England and PTTC New England. We are here to affirm respectful and recovery-oriented of college. We know that we want to bring throughout the week strengths. We want to bring hope. We want to be inclusive, and we want to be avoiding labels while we are here during this week. So I think I now turn it over to our faculty member, our partner. Actually, this event has been possible because we did partner with the William James a while ago, and we started this amazing collaboration. And we have Maggie Gill. She's going to be our director of ceremonies for today. She's a faculty member and a coordinator of the Alcohol and Drug Education Psychology training at William James College. Professor Gill has over 35 years of clinical and leadership experience with clients experiencing problems due to alcohol use disorders, mental health disorders, trauma, and has provided training, technical assistance, and consultations on adolescents, young adults, and substance abuse co-occurring disorders. So Maggie, is an honor to make this a reality. So now I turn it over to you.
Thank you so much, Maria. It's such an honor to be here and to kick off what is going to be a really fabulous 4 days of presentations. It's been a long time planning this conference, and very, very excited that the day is finally here and we're ready to get started. So I hope all the themes that you're going to be hearing about today will be continued and sort of explored in more depth in the days to come. And so I hope you're all able to join us for all 4 days of this very important conference. It is my great pleasure to introduce the president of William James College, who's going to welcome us and sort of kick off the festivities. Dr. Nicholas Covino is the president of William James College and a practicing psychologist. His clinical career has been devoted to caring for the psychological needs of medical patients and engaging in long-term psychotherapy with adults, and his research interests have mirrored his clinical work. Before coming to William James, he was the director of psychology and director of training at the Beth Israel Deaconess Medical Center in Boston. He's also a psychoanalyst and a member of the Boston Psychoanalytic Institute, and it's my great pleasure to welcome Dr. Covino.
Thank you, Maggie. This is a wonderful moment. I'm very grateful to be included in it. Thank you very much for that. If you go back in my biography to the very beginning of my career, I started my career as an alcoholism counselor doing educational work in high schools because I had been a high school teacher. I knew a very modest amount about what I was doing at that point, and I remember being incredibly supported and welcomed by the practitioner community of folks that were taking care of folks with alcohol and other substance use disorders. I would call a bunch of people and they would welcome me into their office. They'd give me things to read. They'd offer to talk with me about places I was stuck. I think that type of welcome, that type of support, that type of collaboration is what typifies the group of folks that work with folks that are the people we're talking about and the people we're caring about today. So thank you all very much for what you're doing. On the one hand of our collaboration and cooperation and willingness to share skills and questions with each other, we know that our history in this field has been a complex one. We've not always been supportive. We've often been divided. We've often been fractured. And our capacity to create a kind of welcome for our patients, especially our patients of color, has been much less than desired and desirable. So a day like today, a workshop like this, speaks to the best of us and speaks to the work that needs to be done. I'll close by, again, thanking you, because this is my family also, not just my family of clinicians. Some of you know I lost my nephew to an overdose. I've been terrified all year because I have an adolescent young man that has a serious depression, whom I worry greatly about. This is what we all live with, all of us, all of our families live with this, and it's of particular concern to communities of color that often are not in the best place to receive the kind of quality of care that we need to demand is there. So I looked around the squares when I could quickly. This is not a group of very young professionals, let me say. This is a group of seasoned professionals, let me say. That people take the time to invest in this work and continue to think about getting better at this and helping each other to get better at that, I think is testimony to your enormous professionalism. I'm proud to be among you, proud to be a sponsor, and grateful for your work. Enjoy your next several days.
Thank you so much, Dr. Covino. I would like to welcome some very special guests we have joining us on this first day to help us kick off our conference. Starting with, it is my great pleasure to introduce now Taylor Bryan Turner from the Substance Abuse Mental Health and Services Administration. Ms. Turner joined SAMHSA from the United States Department of Housing and Urban Development's region, where she was a regional administration office, where she served as a management analyst. Ms. Turner was responsible for implementing HUD initiatives that focused on ending homelessness, promoting affordable housing, health and wellness, and sustainability, and has over 20 years of experience in cultivating diverse relationships among stakeholders, elected officials, and private and nonprofit organizations. It's my great pleasure to turn this over to Ms. Turner.
Thank you so much, Maggie, and good morning. Thank you, Mr. Covino, for your words. We look forward to working with William James College on a project to uplift all clergy in Region 1 and support whole person care. You mentioned families. Dr. Vivek Murthy said, humanity is really only a family of families, really, isn't it? So I appreciate your comments. Welcome everyone again, and thank you for spending the week with SAMHSA colleagues with each Technology Transfer Center. This broad collaboration between each specialized center really embodies the coordination it takes to care for each person holistically. First Lady Michelle Obama said in 2010, the physical and emotional health of an entire generation and the economic health and security of our nation is at stake. In 2022, that is still true. This week, we gather full of energy and optimism on the work that will continue to get done together with inclusivity at the heart. We are celebrating the providers who love unconditionally to ensure whole person care is accessible and equitable for all people who are living with behavioral health conditions and supporting each other as we work to reach that same goal. Together, we solidify the 8 dimensions of wellness: emotional, coping effectively with life and nurturing healthy relationships; environmental, enjoying good health by occupying stimulating environments; emotional, coping effectively with life and nurturing healthy relationships; intellectual, expanding on knowledge and skills; financial, current and future stability; occupational, personal satisfaction and enrichment; physical activity, healthy foods and sleeping; social, developing a sense of connection and belonging and having a good support system; spiritual, expanding one's sense of purpose and meaning in life. These dimensions combined are the best forms of prevention. Today and this week, we will engage each other on how to be that hub of good support. None of those dimensions are successful alone. At SAMHSA, I have been fortunate to have the support of the TTCs to launch the Diversity Inclusion Project Showcase, a convening that focuses on elevating community-based organizations and their population served, who are focused on behavioral health and many different focus areas: faith-based, LGBTQ, youth, formerly incarcerated or troubled young men, yoga, Reiki specialists, and many more. This initiative spotlights community-based organizations for funders and federal partners to increase visibility for funding, training, and technical assistance with our TTCs. Diversity in care, diversity in funding, and diversity in treatment is crucially important in order for us to be successful. I am honored that for Black History Month, we are setting the stage for what must continue to seamlessly blend for true healing and hope to be realized. Our collaboration is necessary to cut back on premature mortality due to higher rates of cardiovascular disease, diabetes, respiratory disease, and HIV, high rates of smoking, substance misuse, obesity, increased vulnerability owing to poverty, social isolation, trauma, violence, and incarceration, lack of coordination between mental and primary health care providers, and prejudice and discrimination, side effects of psychotropic medication, and overall lack of access to health care, particularly preventative care. Our federal family in Region 1 have prioritized whole person care and recovery in communities of color by developing at least 3 initiatives in partnership with SAMHSA: the Federal Interagency Workgroup on Opioids, the New England Federal Collaborative on Recovery for People with Serious Mental Illness and Serious Emotional Disturbance, and the Regional Resiliency and Equity Collaborative that focuses on maternal health, strengthening faith-based relationships by elevating their courageous effort in community and highlighting their funding and training needs that have catapulted during the pandemic, and ensuring that the 988 crisis line is a widespread solution for securing mental health supports, circumventing law enforcement, and providing critical mental health need for co-occurring disorders. These efforts are led by Paul Jacobson, Acting HHS Regional Director of the U.S. Department of Health and Human Services, and I am pleased that he has joined us this morning. Please enjoy this week of regional and national changemakers in person-centered care, and allow yourself to be vulnerable, compassionate, and collaborative. Thank you so much. Now to you, Paul.
Well, thank you. Thank you very much, Taylor. First of all, I'd like to thank you and everybody participating, especially President Covino and William James College for convening this conference. I guess if we're talking seasoning, I'm pretty seasoned. Anyway, my name is Paul Jacobs. I'm Acting Regional Director of Region 1. And my day job, I'm the Executive Officer in Region 1 who works closely with the Regional Director. I'm very pleased to take part in the conference, and I hope to learn how I can have a stronger impact on making a difference and improving the lives of those that we serve. It's really my pleasure to be able to introduce my boss, and that's Marvin Figueroa, who is the Director of the Office of Intergovernmental and External Affairs. Since day one of this Biden administration, Marvin has been in the seat and guiding the 10 regions across the country and assisting us in carrying out the Secretary's initiatives, which I know he'll be mentioning. But in particular, I want to say that prior to coming to HHS, Marvin was the, among other things, Deputy Secretary for the Virginia Health and Human Resources Department. But mostly, I'm proud of the fact that Marvin spent some quality time here in New England at the Harvard University Graduate School. So I know that while I couldn't bring him over to our teams, sports-wise, I know that he's had the pleasure of being in Region 1, and I'm happy about that. Again, Marvin leads all 10 regional offices, as well as other things, but across the country, and he's been instrumental in ensuring that all of our offices, fully participate on initiatives to ensure that racial equity, cultural humility to those that we serve. So with that, I'll turn it over to Marvin.
Thank you, Paul. I like to call Paul the mayor of Region 1 because of his years of service. We're just so fortunate to have him there. And thank you, Paul, for that introduction. I also want to thank President Covino, Ms. Turner, good seeing you again, our moderators and our participants. As Paul mentioned, my name is Marvin Figueroa. I'm the director of the Office of Intergovernmental and External Affairs here at HHS. But what does that mean? On a day-to-day basis, my team is engaged in meaningful dialogue with governors, mayors, tribal leaders, civic leaders, county officials on policies, programs, and regulations to ensure that Health and Human Services policies, program, and regulations are informed by your experiences. And before assuming the directorship here at the department, I served as Deputy Secretary of Health in the Commonwealth of Virginia. There, during the high stress of legislative session, the drafting, the fierce floor debates, and ultimately legislative negotiations, I witnessed firsthand the work that your counterparts undertake to ensure that public policy is informed by the real world, be it how it will play out in the hospital setting, how it will be carried out when it touches the justice system and the like. So it is working with you that we were able to guarantee the passage of holistic policies that moves historically marginalized communities to the center, so they're seen, they're heard, and we start to embrace all of our community. There's a lot going on in the Biden-Harris administration, and to spare you a filibuster, I'd like to focus on three administration priorities: COVID-19 response, behavior and substance use disorder, and health equity, as well as pose a couple of questions that I hope that you will be able to help us answer in the months ahead. So let's get started. As you all know, it's been a long 23 months. To date, COVID-19 has claimed the lives of 900,000 Americans, impacted the livelihoods of many more. I was in the Governor Northam's cabinet when we had our first confirmed case in Virginia. Back then, our response was hampered by the lack of understanding of the virus, what it was, how it was transmitted, let alone how to treat those who had contracted the virus. There was little to no testing. Samples had to be shipped to the CDC in Atlanta, and vaccines were months away. There was confusion, containment strategies, community spread, then the disruption to our daily lives. To date, we have more than 210 million Americans who are fully vaccinated, and we know how to keep people safe: vaccines, boosters, treatments, tests, masks, and more. And as Omicron wave subsides in regions across the country, we're starting to hear from politicians and health officials that soon we'll have to live with the virus. But what does that mean? How do we do that? How do we transition in such a way that doesn't put BIPOC communities that have already suffered the brunt of the pandemic at further risk? What information do they need to make the right decisions that will help them and their families? And what kind of resources do those communities need overall to make sure that when we think about opening up, it is in an equitable way? Part of that is behavioral health. Part of our recovery requires us to come to grips with the emotional toll that the virus has had on our lives. Increased suicide rates, record-breaking overdose numbers, grieving families, and exhausted frontline essential workers. I know Dr. Isom, Mr. Lomax, and Ms. Randolph are going to talk about this later on. But it's also important for us to come to grips with the fact that those services that we are making available won't hit communities the same way. So how do we build out a sustainable behavioral health system with an array of services that are able to meet people who are in crisis, but also works upstream to prevent this onset? How can we help push back against misinformation? In recent weeks, as you saw, we pushed out a harm reduction program. It was misconstrued by some opponents. How do you help us ensure that when we put services out in the field, they are received in the way that it should be? Part of that conversation also has to do with Medicaid and reimbursement. because we know that oftentimes the full cost of the service is not necessarily covered by our social programs. More questions. How do you advance expansion in states that haven't expanded just yet? I know that's not a case for Region 1, but that's something that we're asking ourselves across the country. We also know that the public health emergency instituted a medical continuous coverage provision, but when the public health emergency ends, states will have to resume full renewals of other activities that have changed or suspended during public health emergency. How do we ensure that people maintain their coverage? How do we ensure that there are providers out there for when they do need the help, they're able to get those services? And centering all these policies is health equity. This pandemic has brought into focus social and racial injustice and inequity to the forefront of public health. How do we guarantee that we build back better, that we don't get too nostalgic in the past and try to go back to it, but instead of create a future where individuals, again, have the services they need and are not put in unnecessary risk the way that we've seen during this pandemic? It's going to be it's a big conversation that we all need to have. I'm confident that with your help, we'll be able to answer these questions. And I look forward to the discussion today. And before I close, I want to say as a Honduran raised in the Bronx, I can't help but wish these conversations would have taken place when I was growing up. I would have lost less family members to addiction and less friends to the justice system. But I'm also optimistic that subsequent generations of folks who was raised in places like the Bronx won't go through the things that I did, because you are in the vanguard, you're in the forefront of helping to find better solutions that will help us build back better. So with that, I'll turn it back over with appreciation for the opportunity to join you today, and looking forward to the follow-up. Thank you.
Well, thank you so much, Ms. Turner, Mr. Jacobson, Mr. Figueroa, for joining this very important conversation today. Your contributions are so appreciative and so crucial to conversations like this. So thank you so much for taking the time to be with us this morning. When we are talking about, part of the theme for this entire conference is going to be the cost that is borne by individuals when we fragment care and when we silo our approaches to helping individuals, and trying to move together towards a more integrated service provision model instead. And I'm very pleased to now introduce to you Dr. John Kelly from Massachusetts General Hospital, who's going to talk a little bit about the role of language in contributing to stigma or to healing stigma. Dr. Kelly is the Elizabeth R. Spallin Professor of Psychiatry and Addiction Medicine at Harvard Medical School, the first endowed professor in addiction medicine at Harvard. And he's also the founder and director of the Recovery Research Institute at the Massachusetts General Hospital, and the Associate Director of Addiction Medicine at MGH, and the Program Director of the Addiction Recovery Management Services, or ARMS. It's my great pleasure to introduce Dr. Kelly to you now.
Hi, I hope you can hear me.
Yes, we can. Thanks, John.
Great. Delighted to be here with you all. Maggie, thank you for the opportunity and invitation to present, be part of the proceedings this morning. I can't see you, but I know you're out there in cyberspace, but lovely to be joining you. I'm very happy to be here and part of the proceedings on this extremely important topic. As Maggie mentioned, I've been a clinician. I'm a clinician, I'm a researcher, I'm involved in policy, and I've been very fortunate, very lucky to be in this field. I believe for me, such a worthy cause. I've been studying addiction, its treatment, recovery, including stigma and discrimination, because whenever we talk about this topic of addiction, substance use disorders, we are also talking, unfortunately, about stigma and discrimination. And sometimes we hear that phrase, words matter. I'm sure we've all heard that, words matter. That's kind of a no-brainer, isn't it? Of course they matter, of course words matter. That's our whole language, that collection of standardized sounds and symbols which constitute our language, which is our principal means of communication and communicating meaning to each other as human beings. I think the thing is, when we talk about substance use disorders, it's really a question of how much words matter, because they matter a great deal when we're talking, they're a bigger deal when we're talking about stigmatized conditions from which people suffer great discrimination, and particularly people of color and minoritized populations. I began to say, I've been researching this area of language. I didn't particularly get into the field because of this, but of course it goes hand in hand, as I mentioned, with our understanding of addiction. And the language became more and more important to me as I began to think about and look at the language that we have in our field when we talk about these conditions and people who suffer from them. And as part of that, I began to look at particular terms, which I felt were started to grate on me and become very objectionable. In particular, this term abuse and abuser. Let me pitch a quick question to you. People with eating related conditions are nearly always referred to as having an eating disorder, never as food abusers. So why is it that people with substance related conditions are referred to as drug abusers or substance abusers or alcohol abusers and not people with substance use disorders? It's an interesting disparity, isn't it? When you think about that, we never ever refer to people with eating related problems as food abusers. And yet somehow that abuse and abuser terminology has infiltrated, seeped its way into the field of addiction and its treatment. So that particular term began to really get on my nerves, literally, and I began to question its utility and also whether it actually was responsible for maybe stigmatizing people even more. And so myself and colleagues did a couple of studies, randomized studies, where we actually tested this out. And we found that even among doctoral level clinicians who are working in the field of mental health and addiction, they are susceptible to these biases that are actually induced by exposure to certain terms. This includes, most notably, the term abuse and abuser. So when clinicians who are top-notch clinicians were exposed to a description of somebody in treatment for a drug problem, when the person was described to, for example, as being a drug abuser, as opposed to having a substance use disorder, they viewed that person as being more to blame, more deserving of punishment, and less deserving of treatment. And that was just at random. So we can induce this systematic bias by describing someone in certain ways, which is quite disturbing, or on the other side, uplifting in the sense that we can change people's perceptions, even experts in this field who are also susceptible to these biases that can be induced by certain words like abuse and abuser. This is why we're advocating for dropping this particular terminology in particular and adopting person-first language that includes the description of substance use disorder, just like in eating disorders, rather than talking about drug abuse and drug abusers. This has become very important. And we've seen shifts, a movement in Massachusetts, for example. The state has changed its name. It's dropped the term abuse from the old name, which was the Bureau of Substance Abuse Services, to the Bureau of Substance Addiction Services, specifically because that term now has become associated and proven to induce these implicit biases. So words matter? Yes, they matter. They matter even more when we're talking about highly stigmatized conditions and from which people are discriminated against for. We did a similar study in the general public with a sample not of clinician experts this time, but rather the general public. And what we found was even bigger disparities between this term abuse and abuser. People in the general public who were exposed to the term abuse and abuser rated someone who suffered from these disorders as much more to blame, more in need of punishment, less likely to be exonerated, less likely to get well, more likely to be dangerous, and more likely to be socially excluded. So it really does matter how we describe and the language that we use in this field. I'll leave you with one other study that we did recently, which was a very large sample of the general public, 3,600. This was a nationally representative sample of the American public. And what I was trying to do in this study was to try and understand, well, how should we refer to people who these disorders? Should we describe it, for example, as NIDA has done, as a chronically relapsing brain disease, or as a brain disease, or as a disease, or as an illness, or as a disorder, or as a problem? So, and I thought to myself, well, does it matter which particular term we use regarding how we describe these problems? And does it have the intended consequence? Because obviously the more biomedical terminology that we place on these disorders, which they are, of course, biomedical conditions, they are biopsychosocial, of course, but it's mediated through the brain and through brain changes. This is what constitutes, of course, addiction itself, is through these changes in the brain, but it's caused by these psychosocial factors. Does it matter how much influence that we place on different terminology, whether we place it more on the biomedical side or less on the biomedical side and more on the quote unquote problem side, describing someone as having a drug problem? So anyway, we had those 6 terms, and they were randomized to 3,600 US adults, roughly 600 people each at random, received a vignette describing someone as being, having drug impairment and being in treatment. And they were described as either having a chronically relapsing brain disease, as having a brain disease, having a disease, having an illness, having a disorder, or having a problem with opioids. And interestingly, what we found was that in keeping with the idea of emphasizing the biomedical nature of these conditions, when you do that, you actually do reduce blame. It tends to reduce blaming stigma, which is one aspect, one dimension of stigma. Now, on the flip side, what it did also was it decreased, unfortunately, it also decreased the probability that someone was perceived to be able to get well, to be included in society, and to be less dangerous. So interesting, the very same term had beneficial effects in terms of reducing blame, but contrary to expectations, had worsening effects in terms of improving inclusivity into society and lowering dangerousness, perceived dangerousness. Conversely, the term problem, when you describe the other end of the spectrum, when you describe using less medical terminology, describing someone as having a drug problem, what that does is it increases blame, but reduces danger, perceived danger, and social exclusion, and improves the chances that people will perceive that person as getting well and being able to live a normal life in recovery. So it's interesting is that what that suggests, of course, is that we may need to be selective in the kinds of terminology that we use when we're talking about these very stigmatized conditions. When we're talking about helping people get into treatment and access care and pay for care, we may need to emphasize their biomedical nature, which is, of course, a fact. On the other side, when we're talking about reintegration into society, it may be more beneficial to drop the biomedical terminology and talk about more of the psychosocial phenomena of a problem, having had a drug problem or an alcohol problem, in order to help that person reintegrate into society and be accepted more easily, and to realize and obtain, engender the perception that people will be able to recover. We do know, of course, that this is a good prognosis disorder. 75% of people with an alcohol or other drug use disorder will eventually recover. So it's actually a good prognosis disorder. Anyway, I could go on for a long time here, but I'm not going to. And I'm just delighted to be here with you all. Thank you for having me. Reach out to me if you want any more information on these topics. Happy to provide it. Maggie, thanks so much.
Thank you so much, Dr. Kelly, for being here and for sharing a little bit of your work, looking at the role of language in either perpetrating or perhaps in reducing stigma around these very important conditions. So thank you for that, Dr. Kelly. It is my great pleasure now to, we're going to slightly move the order of presenters slightly. I'm my great good fortune to introduce to you now Dr. Jessica Elizabeth Isom. Oops, my slide deck has a mind of its own. Sorry about that. Dr. Isom is an early career community psychiatrist, a public speaker, a medical educator, and a consultant for diversity, equity, inclusion, and anti-racism projects. Dr. Isom is driven by a passion for collaborative leadership. She takes pride in providing the conceptual frameworks and psychological safety necessary to expand the growing edges of her clients and peers, and draws on her psychiatric training and humble background to connect across differences in power, education, and perspective to foster equity in medicine and beyond. Currently, Dr. Isom is devoting considerable time to growing her consulting company, Visions for Equity LLC, which has expanded into a nationally sought-out team of anti-racism coaches and organizational trainers. Dr. Isom, it's my great pleasure to welcome you today.
Thank you very much. And I've set a timer to make sure that I stay within the time constraints. But I appreciate the opportunity to have any space at all to talk with you all today about a really big topic. And I want to, set a frame for why I chose to focus on the content that I did. So typically when there's a conversation about racial inequities, we often focus on the data, and the data is very important. However, we often focus on the what, which is the data at the expense of the why. So my goal for today is for us to focus on the why. Why are racial inequities present? And the reason why is because for us to tackle them, we have to understand why they exist, and we have to understand the landscape that they exist within. So I'm going to focus on that for the time that we have together. And then there are some resources that will be included on the slides that can give you more information about the actual statistics, but I'm only going to reference one statistic in the time that we have together. So at the end of this 15 minutes, you'll be able to describe how some dominant cultural norms, beliefs, attitudes uphold the status quo. And also you'll be able to list the components of an equity-minded approach to addiction treatment. So we can go to the next slide. So just some key terms to make sure that we're all on the same page around this particular topic. And the reason why this is important is because often at times, most of us lack racial literacy. And if you look at some survey data, you'll see that, for example, about a third of Americans as of 2018 still believe that race is actually tied directly to biology. So we have a lot of work to do there. So I often include some key terminology to make sure that we're talking about the same thing. There's lots of different ways to describe race and racism, but they all, for the most part, if it's an accurate definition, have some of these similar components. So race is a worldview, and it's also a social classification that divides humans into groups based on their appearance and assumed ancestry, and that has been used to form social hierarchies. And as I've stated already, biological races are a myth. What we think we're talking about when we have a conversation about race is we think that we're talking about human variation, and human variation is the biological differences that we can find within our species. So how am I distinct from any other person in this room? That is human variation. And it's important for us all to understand that no racial classification has ever adequately explained human variation at the genetic level. Lastly, racism, how can that be defined? It is a system, and it's a system that leverages power to discriminate against specific racial groups to uphold a specific racial hierarchy. And racial illiteracy, as I've already outlined, which is an inability to understand and truly appreciate what race is, what racism is, that actually nourishes modern day racism and is very relevant to this conversation that we're going to have in the next few minutes. Next slide. So I wanted to illustrate for you all what is the evolution, between this relationship between race and racism, because oftentimes we understand it to be the reverse, when in actuality, racism in and of itself produced a need to classify us into different races. So one way of thinking about racism is that it's a set of ideas, it's an ideology, as was described on the prior slide, that's infused into how we think about racial groups. So racism is a way of conceptualizing or a way of deciding how to treat particular portions of the human population. And that decision to treat those portions of the population in a particular way requires a rational explanation. and that is where race came from. And if you look in the history, any sort of text that talks about the evolution of this term, you'll find that race was offered as a rationalization for why we put African Americans into a position of being in chattel slavery. It was an explanation for why we genocided indigenous peoples on this landmass here in the United States, along with many others. It's an explanation for why we've engaged in experimentation, for example, on a number of different groups, including Black and indigenous peoples. So race is a rationalization for racism and was produced again after that treatment had already occurred. So on the next slide, it's important to understand that because that is why we have race-based inequities. They are not happenstance, they are deliberate, they are intentional. And although in the present day, not as many of us are committed to those being perpetuated, committed to those being longstanding, we still have to understand that there was an intentionality to it previously, and there's an ideology to it previously that still exists inside of our minds to this day. So what do I mean by that? Well, that underlying ideology that races represent groups of people who have an inherent value. Again, that inherent value assigns them to a level within the racial hierarchy that has basically been baked into how we make decisions about what we recognize as a substance use disorder, and then what we do with people who have made use of substances in such a way that it's caused a problem for their life. So on the next slide, I could list for you all of the statistics that would capture what this slide is representing, but I think it's much more important for us together to sit with the fact that that ideology, those ideas about people that is manifest in this definition of racism have produced the inequities that we see in all of the different papers and videos and podcasts and conversations that talk about inequities. So what will you see in that literature and in those other types of communication? You'll see that there are inequities in media coverage. There's a representation, for example, of Black people who make use of drugs as being criminal, or as in lacking some moral, characteristic that would allow them to distance themselves from that particular substance. You also see inequities in research. There was an article that came out in the past couple of years, for example, that talked about how we fund researchers. So for researchers such as Dr. Ayanna Jordan, who is specifically focused on the Black community, her and her team's ability to get funding from NIDA or the NIH is limited by racism. So when she, for example, decides to focus on a community-based intervention, as opposed to something that might be medication-based, or if she says in her proposal, I'm going to specifically focus on the Black community, racism baked into the research world influences her access to the funding to do the research that would help this specific neglected community. You also see racism in how we are able to access treatment. Where is treatment located? What kinds of treatment are available? Are the places where we're offering treatment to racialized minorities places where we have access to all types of healthcare professionals that could benefit patients? Are we able to offer FDA-approved medications, for example? Do we have Suboxone available based on zip code, those sorts of things? Referral types are also important too. Are people being referred from their primary care doctor to some kind of service within their clinic? Or are they receiving most of their substance use disorder treatment and or dual diagnosis treatment from the criminal justice system? Those referral types are important to consider. And as far as what happens when people actually engage in treatment with us, how sensitive and responsive is the treatment that we offer? Are we all going through training programs and structuring our institutions that offer treatment to make sure that it's something that would be relevant and sensitive to every single person that will walk through the door? Or are we structuring our services and our programming through a white dominant racial lens? Drug policy is also a very big part of the conversation. Again, if you look at how the crack epidemic versus the opioid epidemic of today has been regarded, not just by the media, but also by policymakers, you'll see there that underlying racial ideology, that racism has affected those conversations as well. And I think it's important to acknowledge that it's not just us as people providing care who recognize those differences, it's also the patients or consumers or clients who are accessing that care are aware of this as well. So what does it mean to be a person who's seeking services, recognizing that you don't have an opioid use disorder, for example, so there's no funding for you, and that the only reason there is funding right now for a number of different programs however innovative they might be, is because right now the media is highlighting a particular demographic that is valuable, at least in the collective consciousness of our country. The level of engagement is also impacted by racism. If we're not tailoring our services to those who are accessing them, that's going to affect their ability to maintain a relationship with us as providers and a relationship with our particular clinic. And it's also important to think about retention rates for that reason. If we're not offering sensitive and responsive services, people don't have access to coverage to get in the building. If we're racially microaggressing against the people that we're supposed to be helping, that will lead to people leaving the services that could have been useful to them. Next slide. So I said one statistic, and I show this one because it's important to recognize that there are intersections of experiences. And with this particular demographic, people who make use of substances and run into some challenges in whatever areas of their life that are important to them, they are a disparity within a disparity. So this is just one statistic based on a national survey on drug use and health, just showing that at least in 2019, only 2.6 million of the 21.6 million people that needed treatment actually received it. If I stopped here and just said that statistic, I would be offering what really is a colorblind analysis of the issue. We would have to look at that number in a disaggregated way to have a better appreciation of how racially minoritized groups and other marginalized groups are experiencing a disparity within a disparity. Next slide. One thing to think about too is that, again, this conversation is happening, and a lot of it's been being driven by those who access our services, and also those very same individuals might be offering services to others. They are revealing what some of us might reference as blind spots, or just spots that we are not able to recognize or refuse to recognize in everything that we refer people to. And I can say, as a psychiatrist, I've been trained to, for example, refer people to community-based programs, peer support networks, and not in those conversations, there was not a conversation about how colorblind racial ideology, for example, would shape that person's experience and their ability to engage. What do I mean by that? Well, people who believe, and also systems that believe that we're in a post-racial society, will have very strong and often negative reactions to discussions of race and racism. And Nyla Christian, who this quote is pulled from the Drug Policy Alliance website, identifies as a Black recovery advocate and a woman in long-term recovery, and offered this quote: "When I wanted to discuss my trauma of being a Black woman in America, they told me it was not relevant to my alcoholism." So if I'm sending a person to a program, or I'm referring them somewhere, and they show up ready to engage and talk about not just their lived experience, but also what the literature supports as something that's relevant to their relationship with substances, and they're told it's not relevant, not only is that gaslighting, but it also contributes to the perpetuation of the problem. And I just put here on the right a visual representation of some of the data that's in this particular reference here that talks about how racism affects the age of first use of a substance. It affects how we structure the services that we offer, which ultimately translates to us not really offering consistently culturally relevant assessments or treatment interventions. Racism also affects our ability to establish a relationship with those that we're working with. One example of that is racial microaggressions. One example of a way of thinking is that colorblind racial ideology. And then ultimately also racism negatively impacts retention. It's harder for you to stay in a treatment setting, for example, when you get upset and a nurse looks at you as if you're going to hurt them. And these are stories that people tell when they're going to detox centers or other treatment programs that really highlight an under-recognized issue that affects, again, how people are able to engage with the services that we have to offer. Next slide. I wanted to also pull out, again, how this ideology affects our idea of deservingness. And there's an idea of deservingness that's explicitly stated, but also implicitly understood. And one way of thinking about deservingness is, what are we willing to tolerate, right? So if deservingness is defined as being worthy of being treated in a particular way, typically being given assistance, what does it mean about the fact that we are considering some people to be deserving and others not, specifically across racial categories? So a way to get at that question with yourself, or maybe in conversations with others, could be, or that answer could be, what is a substance use disorder versus a crime? Or for whom with opioid use disorder is a treatment program referral more likely than jail or prison? And lastly, what American demographic galvanized federal, state, and local government to invest in treatment and services for use of drugs? And I offer this because sometimes in these moments where we're making at a clinic or institution level a decision, but very often at higher levels, like in the federal government, we're having conversations that are sometimes very hostile to describing what is the underlying foundation of the answers to these questions, which again is that racial ideology that I referenced earlier. If we're not going to talk about our existence in a race-based hierarchy, we're not going to be able to answer these questions accurately, and we're not going to be able to solve the problems that need to be solved. So if you're in conversation, trying to address an inequity, these are the kinds of things that you have to think about and wrestle with, and also encourage others to see fully as well. Next slide. So some goals for anti-racism and substance use and addiction treatment might be disrupt the pervasiveness of colorblind racial ideology. This means directly address how we've been, in some ways, indoctrinated to believe that we are in a post-racial society, despite the facts suggesting otherwise. Goal number 2 might be identify racism as a social and structural determinant of health. If you look at the Kaiser Family Foundation, for example, representation of determinants of health, they show racism and discrimination as crisscrossing all of the different domains that we talk about, from food and nutrition to the built environment to healthcare to the educational system. And goal number 3 might be improving our existing policies and practices through incorporation of a race equity framework. And the last thing I'll leave you with is a way of thinking about how do we get prepared for doing racial equity work. So on the next slide, what I've detailed for you all is a way of thinking about what this could look like. And I am a psychiatrist. I do not only prescribe medications. However, it is one of the things that I do on a regular basis. So I frame this as a prescription, and the prescription is of an equity mind. And I believe we all need multiple doses daily for as long as it takes to address the inequities that we see. So an equity-minded approach, this is adapted from a framework from the Center for Urban Education. Their framework was specific to the learning environment. This is more specific to us in the context that we're talking about. So this means that you are someone who adopts a racial consciousness. You recognize that you yourself have a racial categorization. Others do around you as well, and that comes with a history. You're also committed to an awareness of how your understandings, your language, or behaviors can negatively impact racially and ethnically marginalized people around you. And it's not just patients, but also your colleagues and staff that you're working with. With this mindset, you're also willing to be accountable to history and its consequences. That means that you take responsibility as an individual and as a collective for addressing inequities. And lastly, you're racially literate enough to go beyond just that interpersonal level of racism to understand that there are structural things to address as well. And with that said, I timed myself and I have 8 seconds left to say thank you for listening. And I have some contact information there, and they'll send out some resources for additional information on the points that I made. Thank you.
Look at that. That's wonderful. Thank you so much, Dr. Isom. I'm always so inspired by your work and come away with just so much new knowledge. It's just always such a pleasure to hear from you. Thank you. We also put a link to Dr. Isom's Vision for Equity LLC in the chat box, and then so you can link directly to it. And here's where you can find Dr. Isom on social media and and her email address. So thank you so much. At this time, we're going to take a break, being mindful that being on Zoom can, sometimes be tiring. So we're going to take a mindfulness break. I'm going to share with you. We have a mindfulness moment that we're going to, I'm going to pull up here. If you bear with me for 1 second. Make sure that there we sorry about this. So we're gonna take a 10-minute break. I have on it is now 11:57. We're gonna resume at 12:07, and we're gonna leave you with this mindful break for about 5.5 minutes, and we'll resume at 12:07. So I'll see you back here soon.
Hello, my name is Dana Asby, and I'm a coordinator at the New England Mental Health Technology Transfer Center. We're funded by the Substance Abuse and Mental Health Services Administration. Today, I'm here to bring you 5. Our first habit is to be present. That means resisting the urge to ruminate on the past or worry about the future, but instead be in the here and now. Adults can help children be more present by planning opportunities for quality time, blocks of time where everyone is able to engage in a shared activity that creates joy. Quality time could be playing board games or sports, creating art, or going on a walk together. Try to avoid technology interference during quality time by putting away all screens. Another way to help cultivate the habit of being present is to practice active listening. Parents and school leaders can model active listening in conversations with youth by making eye contact, resisting the urge to assign judgment or interrupt, formulating a response, or filling in the blanks. Instead, truly listening to each word the other person is saying. Doing this will enhance understanding and reduce miscommunication, which is the cause of most conflicts. Our next habit is to be calm. Calm is a state of mind free from worry or extreme emotion. Children look to adults to be their calm center in times of chaos and uncertainty. Adults can help young people learn how to soothe extreme emotions by modeling it in themselves. For in-the-moment stress, returning to our breath by inhaling deeply up for a count of 5, holding the breath for a count of 5, and then slowly exhaling down from a count of 5 can lower a racing heart rate or a high blood pressure, and then bring a sense of calm to the body. To increase your general level of peace and calm, make meditation or yoga a daily practice. When done consistently, both have been proven to lower anxiety and depression. There are many kid-friendly versions of yoga and breathwork practices on YouTube, and apps like Calm and Headspace, both of which have free programs for educators. Our third habit is to be compassionate. Being compassionate means doing acts of kindness for others without expecting anything in return. Adults can be models of compassion for the youth in their life by treating others, especially those with whom they disagree, with respect and love. Start discussions about kindness you see in movies, among peers, and in the community. For example, after donating money to a charity collection box at the grocery store checkout, explain why it's important to give your $3 of change to a children's hospital, because they need that money more than you do to help children who are sick. For younger children, books can be powerful tools to discuss compassion. Have You Filled a Bucket Today by Carol McLeod is an especially useful tool for explaining the concept of compassion to children. Many educators have developed creative ways of bringing compassion off the page and into the classroom based off this book. Many of these could be adapted for use at home. Our next habit is to be grateful, or give thanks. Research has shown that the simple act of expressing gratitude for 3 things each day can reduce depression. Families and schools can make this a routine by starting a gratitude circle around the dinner table, before bed, during morning meetings, or in the lunch line. Some classrooms and families like to preserve their gratitude in a gratitude journal, where students or family members take turns writing down the things they are grateful for. They can draw pictures if they are younger, and also include mementos of these things for which they are grateful. Our final habit is to reflect. Reflection requires taking a pause to think back without judgment, to express gratitude for our successes, and to learn a lesson from our challenges. Too often, we spend an entire day packed full of meetings, events, commuting, cooking, and a million other things, and we don't stop to take a deep breath until the end of the day. The next time you have a moment alone, walking the dog, taking a shower, or waiting in line, resist the urge to drown out your thoughts with podcasts, music, or whatever your favorite distraction is, and reflect. Many find using a journal to be a helpful tool for reflection. Children and teenagers can reflect using the best, worst part of the day routine. This is where everyone goes around sharing their favorite and least favorite things about the day, remembering to express gratitude and find the lessons in each situation. This routine can be easily combined with your gratitude routine. We hope that you enjoyed these mindful habits. Most families and schools find these to be successful if they truly take the time to start with one habit and add on another each time they've woven the last into their community. The most important thing of all is to remember to take time to take care. Thank you again for joining us. For more information about managing stress and coping skills, please visit the New England Mental Health Technology Transfer website for webinars, toolkits, and other resources for schools, clinicians, and others.
Okay, I'm going to welcome you all back from our mindful break and hope you enjoyed that mindfulness moment. It is my great honor to now introduce to you the Honorable Connecticut Supreme Court Chief Justice Richard A. Robinson. After a long and venerable career in law, Chief Justice Robinson was appointed as a judge to the Connecticut Appellate Court in December 2007, a justice of the Supreme Court in December 2013, and Chief Justice of the Supreme Court in 2018. Justice Robinson's career is complemented by an array of public and judicial service. He is currently on the National Board of Directors of the Conference of Chief Justices. He is at the Conference of Chief Justices Civil Justice Board of Directors, and he is on the National Judicial Task Force to examine states' courts' response to mental illness. It is my great honor to welcome to our conference today, Chief Justice Richard Robinson.
Good morning. Thank you very much. I appreciate that. May I start?
Please
Okay.
do. Thank you.
All right. First, I want to apologize. Things usually don't go sideways here until about Friday, 4:45. But since it started today, Monday at about 5 o'clock in the morning, I think I'll be okay for the rest of the week. That's the good news. So thank you very much for your patience. I've shortened my talk a bit because I have to get back down to the panel of the Supreme Court. But once again, I do apologize. And if you invite me back, I guarantee you I will make it up to you. When I sat down to write these remarks, I had hoped that I could rise to the occasion and make remarks that would be thoughtful, motivating, and uplifting as you begin your conference. But the weight of the last 2 years kept getting in my way. When I became Chief Justice of the state of Connecticut a little over 3 years ago, I knew that there would be bumps in the road. What I didn't know back then is that the entire road was about to be washed out. Sometimes it seems like someone opened a Pandora's box of ills. We are experiencing the pandemic of a century, social and political unrest, and an almost unbelievable polarization of the American people. These rolling waters that we've been in have been an almost unimaginable disruption of our lives. While it certainly isn't a disruption that we wanted, in some ways, it was actually a disruption that we needed. The opening of this Pandora's box has brought new urgency to our need to address some of the old and long-lived flaws of our judicial systems. It has focused our attentions on the problems of long-existing inequities and inefficiencies that have gnawed away at the roots of the flower of our constitutional democracy. The longer that things go on, the more I'm hearing people say, I can't wait until we go back to normal. However, I have to tell you, I don't want to go back to normal. For me, what was normal is simply not good enough when it comes to the state of our justice and judicial systems. Let me give you an example of what I'm talking about. In our normal, about 76% of the people who come through our courthouse doors are either mentally ill, chemically dependent, or dually diagnosed. Yet our criminal laws and criminal justice system is designed for only the remaining 24%. If you were to create a system, would you create that system? I think the answer for most of us is no. And that is one of the things that we can really focus on coming out of this. We've really seen how these inequities come out in ways that we haven't before. The court, my court, our courts have been a silent partner in all of this. I think one of the things that's really come out of this from attending all the meetings that I do for the National State Courts and the other organizations that I'm a member of is that we are finally really beginning to look seriously about addressing these problems. We're beginning to talk about these problems. We're beginning to find ways to deal with these problems. Our normal is also an endless war on drugs that's been waged since the 1970s. A war where the criminal justice system and the courts, the primary answer was to incarcerate individuals who had mental illnesses or substance dependency, who are having problems with conforming their behavior to what society deems appropriate. The problem with fighting a war on inanimate objects, like a war on drugs, is that the collateral damage that we do is to real people. Like many of you, I've seen the consequences of that war at work and even in my personal life. I have a son who is seriously mentally ill. He's a wonderful young man. I'm very proud of him. He's now a computer engineer. He has schizoaffective disorder. And I can tell you, I'm extremely proud of him. He's just a wonderful person, and he's doing very well. He actually had contact with the criminal justice system a few years ago, and I lucked out. We lucked out. The judge that he ended up before was Judge James Bingham, who was just an incredible jurist. He passed away a few years ago. And my son did well because Judge Bingham was the kind of judge who looked at him as the individual he was, an individual with a mental illness. And he fashioned a remedy for society and for my son that worked for both of them. My son got on the right track. He takes his meds. He does very well. But the problem, and I've said this many times, the problem is our system shouldn't be like that. Our system shouldn't be that you landed before the right person or you landed before the right agency. Many of us aren't that lucky. Our normal systems that promise equal access and equal treatment under the law have been failing to live up to that obligation, especially when it comes to some of the most vulnerable members of our society. No, I do not want to go back to normal. And that is where our organizations come in. Yes, opening this Pandora's box has brought us many ills. But if you remember the story of Pandora, the last thing remaining in that box was hope. We need to build upon that hope and use this opportunity to make real and meaningful changes to the populations that we serve. We have the opportunity of a lifetime to reshape our criminal justice systems, to use data-driven approaches to correct long existing inequities, inefficiencies, and challenges to procedural fairness. We have the chance of a lifetime to develop and to sustain symbiotic relationships that will better help the populations that we serve. In order to do, as it says on your website, accelerate the adoption and implementation of mental health-related evidence-based practices across the nation, to heighten the awareness, knowledge, and skills of a workforce that addresses the needs of individuals living with mental illness, to foster regional and national alliances among culturally diverse practitioners, researchers, policymakers, family members, and consumers of mental health services. Now, I realize there are no simple solutions to what we're going through. There's no magic bullets, no elixirs that will bring instant resolution. To be honest with you, at this moment, I don't even know what most of the solutions could be. But what I do know is that we will find the answers through gatherings like this, by getting out of our silos and reaching out to each other and cross-pollinating our ideas and our goals, by using database approaches to better serve the people that come through our doors and the world outside of those doors, by using tools such as sequential intercept models to prevent people from coming into the criminal justice system or giving them a quick off-ramp to get out of the criminal justice system. We have certainly navigated through rough seas for the past 2 to 3 years. There's an old African saying that says, smooth waters do not make good sailors. Well, the roiling waters of the last few years were anything but smooth, and I'm glad that our courts are making the journey together with you, incredible sailors. We have a lot of challenging work ahead. People are losing faith in our systems, especially in our criminal justice system. And some would argue, rightfully so. We must work together to turn that around. The people that we serve are depending on it. The work will not be easy, but we must, and we will get it done. Our task may at times seem impossible. And this is where another African proverb comes to mind. If you want to move a mountain tomorrow, you must start by moving stones today. It's been a long, tough road for our people, our way of life, and our institutions. But as my wife often reminds me, the struggle for the United States to live up to its promises of liberty and justice for all is not a sprint, but a marathon. We will always have our flaws. After all, we are all flawed simply by being human beings. Yet we still have our most valuable and cherished principles and dreams. Their survival is worth every ounce of our energy and our ability. In conclusion, I would like to end with these words. I'd like to end these remarks with a quote from Representative John Lewis. Ours is not the struggle of one day, 1 week, or 1 year. Ours is not the struggle of one judicial appointment or presidential term. Ours is the struggle of a lifetime, or maybe even many lifetimes. And each one of us in every generation must do our part. I'm sorry that I had to shorten my remarks, but I assure you it was necessary. We were dealing today with a rather critical matter with the court. And so I have to cut this short, but I promise you, if given the opportunity, I will make it up to you. Thank you.
Thank you so much, Chief Justice. That was wonderful. And it will definitely take you up on your offer to come back and join us at another time. We'd love to hear more from you. So thank you so much for making time in your busy day to be here with us.
Thanks for having me.
Thank you. It is so we have spent, we've had some powerful conversation this morning about sort of setting the stage. And what we wanted to do to wrap up our time together today is to turn our attention to what we call an innovation spotlight and to highlight 2 programs in the greater Boston area that have, in light of what we've talked about so far this morning, have been seeking ways to offer innovative and whole person care, and so we can all learn a little bit about their experience of how they came to do that. So it's my great pleasure. We're going to have sort of a panel presentation starting with, it's my great pleasure to introduce Mr. Doug Lomax. So Mr. Lomax is a program manager at the Boston Public Health Commission, and he is the men's trauma support specialist at a program that you're going to hear a little bit about now, the Corey Johnson program at Roxbury Presbyterian Church. After we hear from Mr. Lomax, I'm going to introduce you to Ms. Leah Randolph, who is the co-founder and executive director of the Commonwealth Mental Health and Wellness Center. And she is also the president of the Boston chapter of the Mass Black Alcoholism and Addiction Council. And it is just such a pleasure to be able to hear from both of them and to have a conversation with the 2 of them. I'm going to start out with Mr. Lomax, who's going to tell us a little bit about the Corey Johnson program.
Hi. Hello, can you hear me?
We can. Hello.
Oh, okay. All right. Thank you for having me, and also Colleen. She's not here, but she is actually director, right? Our clinical director of Can We Talk, right? And a little bit about Can We Talk. Can We Talk is basically a community-based program, right? That is a program that really is about having conversations within the community and having conversations around trauma. We live in a community that is constantly traumatized. It's important that, and we have a couple of different components, right? We meet every Thursday from 6:30 to 7:30 on Zoom now. Prior to Zoom, we met in person, right, at the church at Roxbury Presbyterian Church, which you can see that's up on the screen now. And once COVID came in, right, for the past, 2 years now, we've been meeting on Zoom. And the way it works is that people come and people share their pain, they share their trauma. And in sharing their trauma, we create an audience or an atmosphere that is basically very safe for people to talk about their pain, their trauma. You can move to the next slide. And so the social impact, right, which is the program within the church, Roxbury Presbyterian Church, is located on the corner of Warren and Woodbourne Street in Roxbury, Massachusetts. Excuse me. And because of its location, it has a lot to do with dealing with the community needs in response, to issues within the community. The Corey Johnson program, post-traumatic stress healing program, actually began in September 11th. September 11, 2014. And actually it was developed because Corey Johnson was a young man that attended Loxbury Presbyterian Church and was gunned down, was shot. And his family wanted to do something, right? Something positive around his death. And so it came up with the idea of having a program that really dealt with community healing and community trauma. And one of the things that we, are really conscious of is that our community is suffering from multiple layers of trauma, and because of that, we have been able to design different groups, different counseling, different ways of reaching into the community and creating a platform or an audience for the community to come and really begin a healing process. One of the things that we ended up realizing, right, is that there were a lot of mothers who had lost children to violence throughout our community. You can move to the next slide, please. And in that, we had to look at, how do we, put together a program that's going to sort of support everybody, right? One of the things about trauma is really, understanding, right, the increased awareness of understanding trauma, post-traumatic stress, right, complex trauma, grief and loss, which a lot of the people in the community experience, right? And then they have no place to go talk about this, right? They could go to sometimes their local churches, right? They may be able to find a therapist, but there wasn't nothing that allowed them just to vent and just talk and not really look for answers or try to fix anything, because no one's trying to fix anybody. So we end up realizing that creating this place of safety for the community to begin to try to cope with some of their pain, right? And then learning stuff about trauma. We were able to learn that, the body, right, really goes through a lot of trauma when it is dealing with, right, a dramatic incident or a traumatizing incident. So we've learned to practice, body movement, healing your body, education, mindfulness. The key thing is really about sharing your story, allowing people, right, to share your story. So when we used to meet in person, people would come to the downstairs part of the church, they would go to the mic, and they would take maybe 5 minutes to share their stories. And in sharing their stories, we just listened. And it wasn't a question and answer thing. It wasn't, a place where there was feedback. It was just a place for people to share their pain. And I remember people going through the process of, going up to the mic and saying, you know what, my son or my daughter had died maybe 10 years ago, but this is the first time I'm talking about it. And they've been holding that grief, that pain, that trauma for that long. And then they would start to talk. And when they started to talk, there was a release that just happened, not just with them, but within the room. So we realized that creating this safe place was something that our community needed. We also realized that it was important to connect with the mental health piece. And we've had mental health counselors And we've had our mental health clinician that's always on site, right, or always on the Zoom call now on every Can We Talk, because we understand, right, that people, when they get a chance to begin to talk about their trauma, we just can't leave them wide open. You know, we want to be able to provide some support, to provide some connection, to provide, you know, just the layers of trauma that they're dealing with. How can we come in and support that? Let's move to the next slide, please. You know, so it's important when we look at what we call community companions. So we've had trained community companions who have all gone to trauma-informed training. And the community companions are folks who've actually experienced the trauma themselves. They're mothers who have lost a child. There are people who have had different kind of trauma within their life. It might be addiction, you know, might be prison, right? It could be a number of different related traumas, you know. So we have community trauma healing specialists. You know, we start our program off with an artist. So usually when we start the program off, we have an artist that's either singing, opening up singing, or our other artists who actually may dance. So we usually have 2 or 3 artists that throughout the session will interject either a dance or a song, and it sort of just flows. And as intense as it is, you need that little break, right, to sort of just bring a calmness in. So Can We Talk, you know, we focus a lot on trauma education, especially during the times that we're in person. We will have certain days that we do an education and a healing around trauma. A trauma-informed team, right, access chaperones and support systems to the various people who come when they're in person. Our mother's support group, and these are mothers who have lost children, right, to either homicide or some other form of death, right? The men's support group, trauma group, is really encouraged because these men are men who are caught up in addiction and who are trying to work their recovery. And we understand that, you know, addiction is another form of trauma. It's another layer of trauma. So we do our best to cover the gamut in a safe way. Next slide, please. So when we think about the community conversation and we think about the different barriers that we're dealing with and, you know, sharing our stories around trauma, it is so important, first and foremost, that this is a safe place, right? We always have a mental health clinician available. Our community companions, right, are folks who are trained in how to support people who are sharing their stories, especially when we're in person. They'll probably have a water to bring a person or a box of Kleenex if that's needed. You know, it's important that when we look at the levels of trauma that our community deals with and how we really have to cope with it, it's important when we recognize the different populations. And, you know, people of color, and I always say this, Black and brown people are born into trauma. I'm born into trauma. You know, I was born into systems of trauma that was there to traumatize me from my birth. The privileged community are not born into trauma, they're born into privilege. And so when we have to begin to look at how we survive, right, and how we have to maneuver and strategize as people of color, Black and brown folks, right, that's an awesome amount of energy and trauma that we deal with day to day. You know, it's important that we realize that we have systems that are in play right now, right, that are about traumatizing. You know, I think, and mainly because this is a recovery conference, you know, when I think about the recovery community, and right now the recovery communities, those that who are providing services, detoxes, programs, halfway houses, different, you know, programs that are there to support the recovery community. I have to be very open around the fact that you have people who are going into recovery right now. And a lot of them are from the privileged community, right? So they don't look like me, right? They're from the privileged community. But a lot of them, right, that have that privilege will go into programs that have people that work, that look like me, who are health aides and other things, and will begin to call people out their name, like me, call me the N-word, or call the workers the N-word, right? And that's the problem with that, is that your administration is primarily the administration of the privileged community. And they will not do anything. They will allow that privilege, their privilege, the client's privilege, to act out and call people out of their names. And this is a form of not just trauma, it's a form of terrorism that are going on in our agencies. And so we have to begin to ask yourself, because I remember years ago in old recovery, there was a certain sort of code that when you get to a place that you start disrespecting people's race, there was a thing called an administrative discharge, and you was gone from that program. But that no longer happens. Right now, you have the privileged folks going into programs in the brown and Black community and calling people out of their names, and your administrations won't back up the workers. So they get double traumatized. You know, and so this is something that we need to look at as agencies and how to heal this. You know, it's important when you begin to understand, right, that at this time, right, the different pandemics, you know, COVID has changed the game in terms of pandemic and how we're going to service folks, you know, even going into the future. But the racial pandemic has gained a lot more ground. And some of us are just trying to ignore it, which creates levels and levels of trauma within our systems. And so you have Black and brown people who are being traumatized by clients and then traumatized by the administration. You know, so it's a double whammy. And so it's just something that we need to look at. You know, I think about you know, the recovery schools. And the recovery schools are great, but ask yourself, are they for everyone? Does everyone have access to these recovery schools? You know, because of my last knowledge of the recovery schools, right? All the drugs were allowed except marijuana. And I say to myself, now maybe that's changed, but it's like, who smokes marijuana? Brown and Black. So if that's the case, right, you have systematically moved against the whole population of kids that can't have access. Now maybe that's changed. It wasn't, you know, years ago, that was the way it was, but maybe that's changed. Maybe they're letting marijuana people in. But that's something SAMHSA has to look at. The SAMHSA has to be the one to say, wait a minute, why are we excluding these people, right? And we allow everyone else in.
Yeah.
So it's important that we begin to look at the trauma that is in our community,
Yeah.
the levels of racism that are in our community, you know, because, you know, we just don't want to be going forward and disignoring my people who are on the front lines, and the administration is not supporting them on the front lines, and they're being called the N-word, right, in these detoxes and these halfway houses and these holding places, right? You know, because as I said, we as a people are born into trauma. We're born into systems that are designed to traumatize us over and over and over and over.
Yeah. Mr. Lomax, I want to just thank you so much for really setting this important frame for us all and sharing a little bit about Can We Talk and the Corey Johnson program. I think you just provided us a perfect segue to expand the conversation and to see, hear a little bit from Ms. Leah Randolph about her work, both at her agency and with MBAC. Maybe Ms. Randolph, if you want to join the conversation here and sort of pick where Mr. Lomax left off.
Sure.
Thank you again for allowing me to
Thank
share.
you so much, Mr. Lomax.
Hi, Doug. It was great hearing from
Hey,
you.
Leah, how you doing?
I'm good, thanks. So this is a very small community, and I'm grateful to be here today. Thank you so much for inviting us, Maggie, and I say us because I'm not an individual. I come as a group of people, and today it's just my honor to be able to represent the people that trust me to be able to speak the words that reflect how our community, the Black community, has been impacted not only by substance use disorder, but the reason, and Doug, you did a really good job sort of bringing that all together. So I'll go back to 1991. I became involved with First Incorporated for individuals recovering sound thinking. It was one of the first Black owned and operated substance use disorder treatment programs in the Commonwealth of Massachusetts. And it came as a result of a need from men that were incarcerated in Deer Island, and they did not have alternative ways of getting sober. So they would, go back and forth to jail because their addiction was leading their lives. And so they had to be able to, afford to pay for the addiction. So they started for individuals recovering sound thinking. And being involved with this organization, really gave me a grassroots understanding and approach to the need for culturally based treatment. And at that time, I didn't really understand what that meant. It was all still very new. And, as time went on, I started to realize that, it was important because what First did is that it involved the community. It involved people who lived in the community, who grew up in the communities, whose family were from the community. And therefore, it helped them to be able to learn how to survive in the community in a life after drugs and alcohol and trauma. So, being in the community helped us to be connected, not only to the families, but understanding the importance of legislation, understanding the importance of building relationships, understanding the importance of spirituality and how that relates to Black people. And then at one point, First merged with a Latino program that was having some problems. And that's how First got the Latino program. So we had a men's program, a women's program, a Latino men's program, and a program for families, and outpatient treatment. So what happened? Well, I think really what happened here was politics. That was a time when they would pit the Latinos against the Blacks in terms of treatment modalities. And so at that point, they decided that the Latinos were the new kids on the block, and that they were going to, the powers that be, as they were going to focus more on treatment for the Latino community, and felt that the Black community was all taken care of. Well, we weren't, because treatment is ongoing. And, you have to have funding, you have to have all these things, and new laws and rules and stipulations came into place. So you had to have money to be able to keep up with that. And unfortunately, the money started moving in another direction. I think what we've learned to do through this was that we had to collaborate with each other, and we had to build bridges with each other in order to understand that it wasn't just about one community versus another and allowing anybody to pit anybody against each other. It just sort of goes back to, how it worked with slavery, and understanding how people were, how Black Africans were brought here to the United States and treated like, and treated the way that they were treated, that we were treated. And then how other communities, people of color from other parts of the world came into the United States, and they had to find someone that they could stand on or stand above in order to make themselves feel better about themselves. And this is just sort of the way that life evolves. But we learned that collaboration was really, really important. So in 1996, I became involved with the National Black Alcoholism and Addictions Council after attending a program in Atlanta, Georgia, that a lot of people would attend. And it was under the direction of Francis L. Brisbane, who was one of the co-founders of MBAC. And at that conference, I really was able to learn about how the spiritual piece was really an important part of treatment. But also what I learned was that there will be more people that do not look like us that will be treating us for the rest of our lives in treatment, and the importance of training everyone to be culturally aware, culturally sensitive, culturally knowledgeable around how Black people survive and thrive and develop through a treatment process. So Impact was a place where I learned I grew up and I learned how to have a better conversation with people. And again, it was a continuation of learning about collaborating and learning about myself and learning about teaching other folks around the impact model, which is really a model that really has to do with strength and empowerment. So at the Black Alcoholism and Addictions Institute, which lasts for a week, the only people that were able to present at that conference were people of African ancestry. And that was done purposely to be able to maintain the integrity of the information. I'm sure there are a lot of people that feel that they're culturally competent and that they can provide information. That was some of the things that we ran up against in having Black programs, is that at one point, we were told there really wasn't a need for that. You can have, anybody can treat anybody because it's all about the addiction, and the addiction doesn't discriminate against color, race, ethnicity, but the world does. And the experiences that people that come from various ethnic backgrounds, like Doug said, it's traumatizing, and therefore, how do you go into a treatment program and expect that someone can cut themselves in half and say, this part of me is the addict, this part of me is the Black person, I'm going to let that go right now in order for me to get better. It's impossible. And so that's one of the things that Impact works towards, is really helping people to understand that it's a holistic approach to treatment. And that's why FIRST have such great outcome measures, with people being successful and even in woman treatment. FIRST was very successful under the guidance, I think, of myself and Florence Harris Knight and a bunch of other people. And we learned that one, like a TC model that worked for males didn't work for females. And we learned that, that and that's a part of culturalism, is really understanding that there are things that work for males, that work better for females, that work better for youth, that work better for older adults. And so we have to, so that's just what treatment is. And so in 2000, First was in a lot of trouble. We had already been moved the agency and collaborated with another agency, and the company was drowning. So we became involved with a company called Human Resources Development Institute out of Chicago, Illinois, which was the largest Black-owned and operated behavioral health company in the country and in the world. They had treatment in Africa and other parts of the world, as well as throughout the United States. And so again, another learning curve for me was really learning about the professionalism of running treatment programs. That grassroots approach is good, but really being able to understand not only the politics, but the financial aspects of how treatment is run in order to be able to develop and sustain treatment programs that are going to be effective for Black people. So HRDI came in, and those programs were up to a bid, and they won the bid. And but the problem was, again, was culturalism for a company coming into Massachusetts, which is Massachusetts and Boston is very parochial. And so it was very difficult for an outside company to be able to sustain. So that's how the programs really got lost, is that the relationships, one, are not transferable. And so what happened is, as HRDI took over, it was very difficult for them to really become a part of the Boston culture, even though there were people like Brother Kenny and myself and other folks that were working with the company. It was still difficult because leadership was outside of Boston. So in 2006, the company, when first was taken over by HRDI, we went through our struggles of trying to find property for the programs and things like that. But what we did have was the cultural piece, because HRDI was very much involved with feedback, and that's how we met each other. But it unfortunately, it didn't work. And the women are always the first ones to go. So the women's program was gone. The Latina program was gone. The Women and Children's program was gone. And the only program that sort of got saved was the men's program, and that went over to another agency. And that program became bastardized, and all of the men that had been successful throughout the years that were being referred to that program, it changed, it shifted, because during this time we're seeing a shift in what addiction looked like. So addiction moved from being a criminal-based offense to a mental health and a medical model, because now there are young Caucasian and families that are looking for a way to be able to help their children address their addiction. And so as it became more prevalent in other communities, then it was no longer could be looked at as a criminal offense, because folks didn't want that to happen with their children. But still, during that time and even today, we still are seeing criminal offense. It's not a level playing field, and we all know it. And we still do not have culturally appropriate programming here in the Commonwealth of Massachusetts that really does still address the needs of a particular population. What happened with First Incorporated in the men's program is that it turned into a program for adolescents from communities outside of Boston. And so the model moved towards that. So the men that normally would go to that program didn't feel comfortable going to that program. The program was wasn't meant for them anymore. And so we're seeing, these questions about where are all of the, the Black addicts, where have they gone? Why are they not accessing treatment? And this is just a little bit of information of It didn't happen overnight. It was a process that started from 1996 to today, and it's still continuing. So I felt like, there was a time that we really needed to make a change, and the only way that we could be effective in making the change is that we had to start something of our own. So in 2013, my business partner, David Avery, and I embarked on Commonwealth Mental Health and Wellness Center. And so we're still an outpatient program, but we knew that the comorbid issues that were impacting our communities had to be addressed. So we started with the mental health model and started with doing children's behavioral health initiatives and looking at the entire family and helping from the community from the inside out. We hired people that look like people from the community. We trained people. And, even at one point, we had probably about 6 guys that came to us with undergrad degrees, and all of them now have master's degrees in clinical psychology. And some of them are working on their PhDs. And one of the females has already achieved her PhD. And so this is, we're a think tank, and because we know the only way that we're going to be able to help to overcome these disparities is that we have to empower ourselves and empower our community. And I do need to say that in 2000, I became involved with the Boston Consortium for Women and Families in Recovery under the direction of Dr. Hortensio Amaro. And that's where we first started having conversations about trauma and trauma involvement under a SAMHSA grant. So, everything that people are talking about now, we actually did the work with the Latino Women and Families program and with the program that I was running. And we had positive outcome measures because, one, we started looking at, the difference between substance use disorder, mental health disorder, and trauma. And we no longer just put it all into one basket, but we had to be able to separate it. And I think that was the thing that brought us up to Commonwealth in looking at, yes, there's a mental health disorder, and yes, there's a substance use disorder, and there's a spiritual disorder. And, so how do we make this a level playing field? So Commonwealth Mental Health and Wellness Center, and we called it wellness because we also learned that there are alternative ways of people healing. And the only way that we could really gain the trust of the people in our community was to offer them a model that really talked about how they heal, how to meet people where they are and not judge people, for their beliefs. And so we've had a very successful run. We're still in the game. And in 2020, we applied for our BSAS license. We were providing some substance use treatment, but it was sort of like on a co-occurring disorder. But now we have our BSAS license, and so we're developing our program model to really meet the needs of the people in the community. And we also opened a second clinic in Lynn, where we're looking at the same issues there. And how do we help people, from across the Commonwealth? So I think healing became like very, very important to us in how we help people to want to stay engaged, and so two, to be able to identify those folks. So now we're working on really developing more collaborations with different community-based organizations to do the outreach, because people, Black people are not going to just come to treatment, that they're not going to do that. There's a lot of trust that's been broken, and there's a lot of stigmas that are still attached to mental health and substance abuse treatment. So we are in the process and have been working on developing our healing model that, along with having conversations with people like Dr. Isom and working with other community folks to really pull a strong collaboration of people together to continue this care. We have a person that was in treatment when I was a director, who is now a nurse practitioner, and her focus is mental health and substance abuse. And so we're building from within to really strengthen and help people to understand the power from within and to help each other. So I'm going to close with, just saying that we have a group that we developed. It's called Healing from COVID While Being Black. And we've had such positive outcomes from that. We're going to continue to develop that model and share it because what it addresses is all of the things that that you also talked about, Doug. It's a 12-week program, and it addresses, it uses different theoretical practices. So for the first 4 weeks, we have an artist that works with people and helping them to learn how to disclose themselves, how to let go of, holding on to the secrets that have kept people sick and afraid and all of those things by using their words and by drawing and by writing. And then the next 4 weeks is a piece done with alternative healing, and people learn how to use different kinds of teas and oils and meditation and all of those things to be able to help them to feel better about themselves, to know that there are other ways of them to deal with some of their trauma other than going back to using substances or self-destructive behavior. And then the last 4 weeks is done with a psychotherapist, and they're learning how to really manage themselves and how to utilize different interventions to be able to help them to manage how they think and how they see themselves. So it's important for us to really continue to collaborate, to continue to teach, and to continue to reach back into the community and help people to get past where they've been and to continue to develop our programs. So, it takes a lot. And we're just grateful that we're still here doing the work.
Well, Ms. Randolph, I just want to thank you so much for your remarks, and Mr. Lomax as well. I feel like the two of you brought so many of the themes that we're going to be hearing about for the next couple of days to the forefront. So Mr. Lomax, you talked about whose needs are centered in our treatment programs, how the power of people coming together to innovate and to meet the needs of people whose needs are not currently being met. And then Ms. Randolph, just to remind us again of the power of collaboration and to think not just in terms of sort of more simple outcome measures, but think about healing and spiritual healing as a part of recovery. So I just want to thank you so much for taking the time to share just a little bit about your work, and links to both Mr. Lomax and Ms. Randolph's agencies are in the chat box, and you can find more information about them in the Resource Center. And so now our time has flown by. I want to turn it back to our host from the Mental Health Technology Transfer Center, Maria Restrepo Toro, to sort of close us out for today. So thank you all.
Thank you, Margaret, and thank you to everybody on behalf of all 4 partners, William James College, the New England PTTC, the New England ATTC, and the New England Mental Health TTCs. We are absolutely amazed with the amount of wisdom that we heard today, and please join us tomorrow to continue this conversation. Tomorrow's session will be hosted by the New England Prevention Technology Transfer Center, and we have a great resource for all of you, which is the virtual exhibit hall. In that hall, you're going to find resources from all our speakers to continue these conversations. We are all here committed to continue this work. We will be, if you, I think all of you registered with your email, so you're going to receive a webinar from today with a presentation. And at the end of the 4 days, we're going to submit the required evaluation for the TTCs. It's called a GIPRA link. And what that is really important for all of you to complete that information. So please have a wonderful rest of the day, a happy Valentine's Day, and we'll see you all tomorrow. And we really appreciate coming together today.